Good morning. I'm Dr. NIKITA KHOT. I'll be discussing the pathophysiology of bronchopulmonary dysplasia. So, for a better understanding of the pathophysiology, let's start from the fetal lung development. The fetal lung development occurs in five distinct stages, each critical for forming a fully functional respiratory system by birth. The five stages are embryonic stage, which starts from the third to seventh week of gestation, which includes formation of the lung bud and primary bronchi. The pseudoglandular stage, which is from the 7 to 16 weeks, wherein there is branching of airway tree, terminal bronchioles. Canalicular stage, which is from the 16 to 28 weeks of gestation, whereas there is formation of respiratory bronchioles and early vascularization begins. Saccular stage, which is from the 28 to 36 weeks of gestation, where the terminal sacs are formed and surfactant production starts. The last is the alveolar stage, which starts from the 36 weeks and goes up to 2 years and above. Here, alveoli maturation and multiplication is seen. Efficient gas supply, gas exchange is also established. So, in preterms, in BPD, the major insult occurs at the canalicular stage and the saccular stage. In canalicular stage, the alveolar epithelium starts to differentiate, which allows materialization of the first zones with an air blood or alveolar capillary barrier. There is limited pulmonary surfactant secretion and surface area available for gas exchange. In saccular stage, there is formation of terminal sacs, which are clusters of large enlarged spaces. Cells differentiate to fully secrete the surfactant. Expansion of future air spaces and gas exchange area. Preparation of alveolarization as a fibrous network of elastic fiber and collagen fibrins emerge. So this is a diagram which helps us understand it a little better. So the earlier the insult, the more premature the insult is, developmental arrest or delay is seen, such as the findings of new bronchopulmonary dysplasia. In this, alveolar hypoplasia is seen and decreased capillaries are seen. The later the insult, there is more of a structural injury seen, such as seen in old bronchopulmonary dysplasia. There is airway injury, inflammation, and parenchymal fibrosis. Coming to the pathogenesis, uh, during these above mentioned two periods, especially the canalicular and early saccular stage, terminal air spaces and microvasculature are in the immature lung, expand and prepares for this alveolarization. Hence, they are at a higher risk for developing BPD in that stage. Risk factors, as discussed earlier, can be divided into three main categories: demographic, antenatal, and postnatal. Gestational age, lower the gestational age, higher the chances of BPD. Birth weight, lower the birth weight, higher the chance of BPD. Male children and Caucasian race are at a higher chance of acquiring BPD. In antenatal, there is genetic predisposition, intrauterine growth restriction, preeclampsia and PIH in the mother, chorioamnitis, maternal smoking. In postnatal, there is oxygen therapy, mechanical ventilation, PDA, and neonatal sepsis. This is just a quick overview of how each pathology contributes in developing BPD. In fetal growth restriction, has a significant impact on the vulnerability of the lung injury and vasculogenesis. In prematurity, there is structural and functional immaturity, which increases the risk and disruption of normal pulmonary microvasculature and alveolar development from the external antenatal and postnatal insults. By mechanical ventilation, large tidal volumes, that is voluotrauma, causes overdistension of airways and air spaces. Maternal smoking, it results in decreased forced expiratory flows and decreased passive respiratory compliance, which in turn increases the risk of BPD. Oxygen toxicity is caused by cellular damage, causes overproduction of cytotoxic reactive oxygen metabolites, resulting in the inflammation and lung injury. PDA, secondary to increased pulmonary blood flow, producing an increase in interstitial fluid and a decrease in pulmonary compliance and increased airway resistance. In infections, there is exposure to pro-inflammatory cytokines, possibly due to chorioamnitis and infections. So coming to the pathogenesis of how the injury occurs. So in acute lung injury in BPD is mainly caused by oxygen toxicity, barotrauma and volutrauma from mechanical ventilation. This causes cellular and interstitial injury, which triggers a release of pro-inflammatory cytokines, that is interleukin 1 beta, interleukin 6, interleukin 8, and tumor necrosing factor alpha, which increases the alveolar permeability and recruits inflammatory cells into alveolar and interstitial spaces. This ongoing injury is further mediated by proteases, oxidants, chemokines, and chemoattractants, leading to fluid and protein leakage into tissues. This leads to altered airway and altered vascular tone and damaged mucociliary clearance, which causes secretion buildup, resulting in peripheral airway obstruction, alternating lung collapse and hyperinflation, proximal airway dilation. This in turn impacts on lung development. There is inflammation which disrupts key developmental pathway, leading to impaired alveolarization and emphysematous lung changes. Now, in the chronic phase of lung injury, the structural and cellular changes seen are interstitial changes include fibrosis and cellular hyperplasia caused by excessive release of cytokines and growth factors, leading to dysregulated tissue repair. There is impaired interstitial fluid clearance, leading in a pulmonary fluid retention. In airway remodeling, they exhibit increased muscularization and hyperreactivity. Histologic changes seen are smooth muscle hyperplasia in small airways and glandular hyperplasia in large airways. Physiological consequences seen are there is decreased lung compliance, increased airway resistance, and impaired gas exchange due to ventilation perfusion mismatch and air trapping. The pathological changes seen in BPD are alveolar changes, there is decreased septations and alveolar hyperplasia, resulting in reduced surface area for gas exchange. Pulmonary vascular changes seen are dysregulated vascular development, there is abnormal alveolar capillary redistribution and thickened muscle layer and pulmonary arterioles, leading to increased pulmonary resistance. Early vasculogenesis disruption contributes in pulmonary hypertension, which increases the morbidity and mortality. Interstitial and connective tissue changes. There is increased elastic tissue formation, thickening of the interstitium. These deformities further impair septations and capillary development. So in a nutshell, as discussed earlier, main are antenatal factors, postnatal factors, and prematurity. Quick overview: antenatal factors, IUGR, chorioamnitis, preeclampsia, maternal smoking, extreme prematurity. Postnatal factors such as severe respiratory failure, mechanical ventilation, oxygen supplementation, infection, patent ductus arteriosus, they all contribute in lung injury, developmental arrest, airway vascular damage, and decreased alveoli and capillaries, leading to respiratory failure and pulmonary hypertension, which could cause early respiratory death. If there is repair regeneration, it could lead to disease resolution or further land up in chronic respiratory disease, that is BPD. This is just again an overview of the pathogenesis and clinical findings seen in bronchopulmonary dysplasia. Thank you.